All right, good morning, everyone, and Happy New Year. Welcome to the first grand rounds of 2021. Thank you all so much for coming. I'm Megan, one of the PGY4 Emerge residents, and over the next 50 minutes, I'd like to delve into the world of tranexamic acid with you. My goal for today is to update you on the recent research on TXA for various indications, so you have the most up-to-date knowledge that you can use when treating your bleeding patients in the ED. Our talk today will be divided up into 3 parts. In part 1, we'll refresh your understanding of TXA pathophysiology and our current knowledge base. In part 2, I'll equip you with an evidence-based approach to the use of TXA in various ED presentations, including traumatic brain injury, GI bleeding, intracerebral hemorrhage, and hemoptysis. And in part 3, we'll dive into some of the common TXA FAQs, such as optimal dosing, routes of administration, clinical considerations, and adverse events. Now, as is inevitable when presenting a talk on TXA, we're going to be covering a lot of literature, but I promise to keep it as high yield and as easily digestible as I can for you today. As some of you may remember, Dr. Ghazal also covered the role of TXA in the ED in his grand rounds back in 2015. He covered the CRASH-2 and MATTERS trials in detail and talked about TXA in epistaxis and in heavy menstrual bleeding. Dr. Fletcher also went over the most up-to-date studies on TXA and epistaxis in her grand rounds in 2018, so we're not going to be going over these studies today, but please refer back to their excellent presentations if you'd like more info on these topics. Okay, let's dive in with part 1, where we'll go over the basics of TXA, including its mechanism of action and currently approved indications for use. We'll briefly go over adverse effects and contraindications, and we'll pick up where we last left off in 2015. Let's start with a little TXA 101. Don't worry, I promise not to take you through the whole coagulation cascade. But as you probably know, the #1 goal of TXA is to stop bleeding by inhibiting fibrinolysis late in the coagulation cascade. TXA is a synthetic lysine derivative that binds to the lysine site on plasminogen, and by doing so, it prevents its interaction with fibrin and ultimately inhibits the breakdown of fibrin clots. In other words, it stabilizes a clot that has already formed, but it doesn't directly stop bleeding otherwise. It comes in IV and oral formulations, and it's also possible to use the IV formulation in a nebulizer as well. It has a relatively short half-life of 2 hours when given IV, and is readily available and inexpensive, roughly costing the same as a fancy latte at around $6 per 1 gram vial. Currently, TXA is only FDA approved for use in hemophilia and in heavy menstrual bleeding, but it also has many off-label uses, including in dentistry, orthopedic and cardiac surgery, epistaxis, hereditary angioedema, and others that we're going to go over today. Adverse effects include GI symptoms such as nausea, vomiting, diarrhea, headaches, seizures, and hypotension, which can happen with rapid IV injection, with a lot of concern placed on thromboembolic risks. We'll take a deep dive into the truths and myths about this later today. You'd probably want to avoid its use in those with known hypersensitivity, in those with current or prior history of thromboembolic disease, and some report subarachnoid hemorrhage as a contraindication as well due to concerns regarding an increased risk of cerebral infarction in these patients. Okay, now that we're up to speed on the basics, let's take a couple of minutes to review where we last left off with the last grand rounds, starting with a short video clip produced by the London School of Hygiene and Tropical Medicine.
While Japan struggled to recover from the devastation of World War II, husband and wife researchers Otoko and Shosuke Okamoto were making medical history. Working on blood drawn from their own veins, they identified a powerful inhibitor of blood clot breakdown, a process called fibrinolysis. But the full potential of their brainchild, the drug tranexamic acid, or TXA, would not be recognized for decades. First dentists, then surgeons noted the benefits of TXA. A single dose just before incision cut surgical bleeding by 1/3. But it was half a century later, after the CRASH-2 trial randomized 20,000 bleeding trauma patients to get TXA or placebo, that the world woke up to their discovery. When given soon after injury, TXA cuts bleeding deaths by a third, mostly by reducing deaths on the day of the injury.
So these promising results from the CRASH-2 trial, which we just saw in the video, as well as the MATTERS trial on combat-related injury, showed that TXA was capable of reducing mortality in trauma patients, especially when given early. Again, we're not going to go into detail about these older trials, but I just wanted to go over this really important bottom line because these are the findings that led to the widespread use of TXA in trauma and created a lot more interest in its use for many other indications, which brings us to the next part of our talk today. So in part 2, we'll look at the evidence behind the role of TXA for various indications, including in traumatic brain injury, GI bleeding, intracerebral hemorrhage, and hemoptysis. Let's start with traumatic brain injury, or TBI. Sometimes referred to as the silent epidemic, TBI is a common and potentially devastating disease. Affecting more than 452 people in Canada every day, this translates to roughly 1 person injured every 3 minutes, or 20 people in the short time I present this talk. TBI is categorized as mild when the presenting GCS is 13 to 15, moderate when it's 9 to 12, and severe when the GCS is less than or equal to 8. We know from previous research that TBI is often accompanied by intracranial bleeding, and that the greater the severity, the greater the bleeding. We also know that increased fibrinolysis is part of the coagulopathy of TBI, with hemorrhage expansion happening in the first few hours after injury, and larger hematomas being associated with increased mortality. When taken together, these findings explain why TXA has been of interest in TBI patients. The specific idea behind the use of TXA in TBI is based on the theory that TXA might limit secondary brain injury by 2 means. The first is that it may limit fibrinolysis and therefore ICH progression. The second is that it might inhibit the effect of tissue plasminogen activator, or TPA, which is involved in perilesional edema. A recently published systematic review and meta-analysis looked at 7 RCTs evaluating the effect of TXA in TBI, specifically looking at mortality, hemorrhage expansion, and vaso-occlusive events. They found a lower risk of death in the TXA groups with an overall risk ratio of 0.92 favoring TXA and an NNT of 71. With respect to hemorrhage expansion, they found an overall risk ratio of 0.79 favoring TXA and an NNT of 16. The largest and most recent trial included in this meta-analysis was the CRASH-3 trial. So let's take a closer look at this now. As many of you already know, the CRASH-3 trial was a large RCT published in The Lancet in 2019, examining the effects of TXA in patients with TBI. They enrolled roughly 13,000 patients and included adults with TBI who were within 3 hours of injury and compared TXA to placebo. The TXA arm received 1 gram IV over 10 minutes, followed by an infusion of 1 gram over 8 hours, whereas the control arm received matched placebo. Their primary outcome was head injury-related death in hospital within 28 days. There were several secondary outcomes as well, including head injury-related death within 24 hours, all-cause mortality, vaso-occlusive events, and the risk of seizure. With respect to their primary outcome of head injury-related death at 28 days, while there was a trend towards benefit, there was no significant difference between the 2 treatment arms, with the confidence interval crossing over 1. When they excluded patients who already had a poor prognosis and were unlikely to benefit from TXA, that is, those with a GCS of 3 or with bilateral fixed pupils, they found a similar absolute decrease, but this was just under the cutoff for statistical significance. However, in a subgroup analysis of patients with mild to moderate head injury, TXA was associated with a significantly decreased rate of head injury-related death at 28 days compared to placebo, with earlier time to treatment, that is, within 3 hours, also found to be significantly more effective than later treatment in the same subgroup of patients with mild to moderate TBI as shown on the left side of the figure here. But as you can see on the right, time to treatment did not affect head injury-related deaths in the group of patients with severe TBI. Lastly, with respect to their secondary outcomes, they did note a significant decrease in head injury-related death at 24 hours, but there were no significant changes in all-cause mortality or in risk of vaso-occlusive events or seizures. In conclusion, the authors said that TXA is safe to be used in patients with TBI and that treatment within 3 hours of injury reduces head injury-related death. But I would advise caution when considering this conclusion. If we quickly look at the main points again from this trial, we can see that really the only significant difference was noted in head injury-related death within 28 days in those with mild to moderate TBI, as well as in those with head injury-related death within 24 hours, with no significant differences in adverse events. And so, as was nicely summarized in a post by our very own Dr. Krishan Yadav, their conclusion is somewhat misleading. Yes, there was a reduction in head injury-related deaths, but this was limited to a specific subgroup of patients with mild to moderate head injury and those at 24 hours, and the conclusions drawn from this trial should reflect that. It's also important to note that these results were based on subgroup analyses and should be viewed as hypothesis generating. Overall, this was a huge study that addressed an important question with a large sample size and very few participants lost to follow-up. The biggest limitation was their change in primary outcome during the study from head injury-related death for patients treated within 8 hours to those treated within 3 hours of injury. And even though they tried to account for this with a larger sample size, they didn't meet their target, potentially contributing to an underpowered primary outcome. In a separate sub-study done last year on the CRASH-3 patients, the rates of hemorrhage expansion and new hemorrhage formation were evaluated by looking at the CTs of patients in each group. And while they didn't find any significant difference in hemorrhage expansion with TXA, they did see that in patients with bilateral reactive pupils, TXA significantly reduced new hemorrhage formation. This outcome is similar to that seen in CRASH-3 in the sense that patients with less severe TBI appear to be the ones to benefit the most from TXA. This is likely because patients with severe TBI already have really large volumes of intracranial bleeding and significant coagulopathy, at which point TXA really has little room to work. Now, given that a lot of research has suggested that earlier treatment with TXA is better, the role of pre-hospital TXA in TBI patients has been of recent interest. In fact, very recently, there were 2 trials published in JAMA looking at this. The first, the ROLL study, shown here in orange, was an RCT published a few months ago and looked at whether TXA given within 2 hours of injury was associated with favorable neurological outcomes in patients with moderate to severe TBI. But unfortunately, they failed to find any improvement in 6-month neurological outcome, nor did they find any significant changes in any of their secondary outcomes, including 28-day mortality. The second study, shown here in red, was by Bossers and colleagues and was an observational trial published last month, looking at the effect of pre-hospital TXA on 30-day mortality in those with severe TBI. Unfortunately, they didn't have very encouraging outcomes either. In fact, they actually found TXA to be associated with increased mortality in patients with severe isolated TBI, but it's important to remember that this was an observational trial, so we can't really infer causality based on this alone. So while these trials have their limitations, currently there's no clear benefit to the use of pre-hospital TXA in TBI, and more research is needed before we can fully understand its pre-hospital role. Now let's take a quick look at our practices here at TOH, and thank you to all 80 of you who filled out the survey. Looking at this chart, it appears as though there's quite a bit of variability in terms of our use of TXA for this indication, but the majority appear to report never or rarely using it in TBI. So let's see what the experts are doing in other major trauma centers. In speaking with Dr. Deleuze, one of the TTLs at Sunnybrook, he states that for their patients with isolated TBI, they're regularly using TXA in the trauma bay for those who present with a GCS less than 14, or if there's a high index of suspicion for bleed. If there's any doubt as to the cause of the decreased GCS, for example, if they wonder if the patient might be intoxicated, their recommendation is to first obtain a CT head and then to give TXA if there's bleeding on imaging. The only cases where they're not giving TXA regularly is in the cases of very small traumatic subarachnoid hemorrhages in someone who's otherwise neurologically intact, since the risk of hemorrhage expansion on subsequent CT in these cases is usually less than 1%. So, take-home message. First, focus on your ABCs and ICP management for these patients. Then you can consider using TXA. Just remember that it's likely to be most effective in mild to moderate cases and when given early, and appears to be a safe option. Ultimately, more research is needed to guide our practice, both in hospital and in pre-hospital settings, but until then, I'll be keeping TXA within my reach for my TBI patients. All right, next, let's move on to TXA use in GI bleeding. GI bleeds are a common presentation to the ED, and with case fatality rates as high as 14%, even with our current treatments, it's clear that more effective treatments are needed, and TXA has been given recent attention. Between 1973 and 2014, there were 8 RCTs performed investigating TXA in upper GI bleeds, and these were included in a 2014 Cochrane review on a total of 1,700 patients. Their review found that when using TXA for upper GI bleeds, there was a mortality benefit with an NNT of 29, as well as a reduction in the rates of rebleeding. But the studies that were included in this review had significant bias due to their overall small sample sizes and high rates of attrition. Overall, this Cochrane review ranked the quality of evidence as moderate to low, and it was concluded that more evidence was needed before we use these results in our practice. Since then, only 2 further RCTs have been published, one on locally administered TXA through an NG tube, and the other on IV TXA, which we'll look at now, and that was the HALT-IT trial. This was a large international RCT on 12,000 adults with significant upper or lower GI bleeding, defined as being at risk of bleeding to death. They randomized them to receive either 1 gram of TXA over 10 minutes, followed by an infusion of 3 grams over 24 hours, or matching placebo. Their primary outcome was death due to bleeding within 5 days, although originally they actually aimed to look at all-cause mortality, but this was changed during the study. Secondary outcomes included death due to bleeding and rates of rebleeding up to 28 days, the need for endoscopy or surgical intervention or blood product transfusion, and various complications, among others. With respect to their primary outcome, they failed to find a significant difference in death due to bleeding at 5 days between groups. And their original primary outcome of all-cause mortality at 28 days was also unaffected. If we look at their secondary outcomes, there were also no significant differences between groups with respect to rates of rebleeding, need for surgery, endoscopy, or transfusion, as well as no significant differences in the total amounts of blood products transfused or rates of arterial thromboembolism. But they actually did find a doubling of the risk of VTE, including DVT and PE, in the TXA group, although it was a small risk at 0.8% and with a number needed to harm of 250. They also found a slightly increased risk of seizures with an NNH of 500. So the authors concluded that TXA does not reduce death due to GI bleeding and may actually increase the risk of VTE and seizures, and currently they don't recommend its use for patients with GI bleeding. Overall, this was a strong and much needed study that aimed to answer some very important questions. Their methodology was sound. They had a very large sample size with very few losses to follow up, and they used strict criteria for the diagnosis of thromboembolic events. Probably the most significant limitation of this study was their change in primary outcome from all-cause mortality at 28 days to death due to bleeding within 5 days, but truthfully, I don't think this significantly affected their results. If we look at our practice here at TOH, again, there seems to be considerable variability in our use of TXA for GI bleeds. So let's see what the experts have to say. Dr. Jeff McCurdy, one of our gastroenterologists here at TOH, says that they don't use TXA for GI bleeds and they wouldn't recommend its use in the ED, especially given that the current weight of evidence suggests that it may actually offer more harm than good. So your take home for today is that for now, TXA is not recommended for GI bleeding. While older research does suggest that there may be a mortality benefit, newer and stronger evidence does not support its use. So, will I be using TXA in my patients with GI bleeding? Nope, I won't be. Okay, on to our next section, where we're going to talk about spontaneous, that is, non-traumatic intracerebral hemorrhage, or ICH. To be clear, when discussing ICH, I'm not referring to epidural, subdural, or subarachnoid hemorrhages. Rather, intracerebral hemorrhage is bleeding into the parenchyma of the brain itself that results from a diseased blood vessel. About a quarter of these are complicated by hematoma expansion, which usually happens within the first few hours after insult and has actually been independently associated with death and poor outcomes. In fact, although ICH is responsible for only 20% of overall stroke diagnoses, it actually accounts for half of the deaths related to stroke and significant morbidity in those who survive. Over the past several decades, drug therapies aimed at limiting hematoma expansion have been studied and have included recombinant factor VII, platelet transfusions, and FFP. But unfortunately, based on a recent Cochrane review, these haven't shown any conclusive benefit in functional outcomes or mortality for these patients. In fact, as we know from the PATCH trial, platelet transfusions have been associated with worse outcomes in ICH patients who are on antiplatelet therapy. Over the past few years, more attention has been on other possible therapies, including TXA. So let's look at the most recent and largest trial now, the TITCH-2 trial, which was published in The Lancet in 2018. This was a double-blind RCT that included over 2,300 adults with spontaneous ICH presenting within 8 hours of symptom onset. They were randomized to receive either 1 gram of TXA followed by a second gram over 8 hours or matching placebo. Their primary outcome was the patient's functional status at 90 days, measured as an ordinal shift on the modified Rankin scale. Secondary outcomes included hematoma expansion at 48 hours, change in hematoma volume at 24 hours, mortality at 7 and 90 days, and safety outcomes up to 90 days. And while they didn't find a significant difference in functional status at 90 days between groups, they did find a significant difference in the same outcome when looking at a subgroup of patients with lower systolic blood pressure, as you can see here in those with a systolic blood pressure less than or equal to 170. And this is actually consistent with what we understand about ICH, in that lowering blood pressure is one of the only things that's been shown to improve functional outcomes in these patients. When looking at secondary outcomes, they did have some other positive findings as well. Mortality at 7 days was significantly reduced in the TXA group, although this didn't hold when looking at mortality at 90 days. The rate of hematoma expansion at 48 hours was also significantly reduced, as was the volume of hematoma expansion at 24 hours. But as you can see here, the difference in volume was only 1.2 mils, which is really unlikely to be clinically significant since there were no significant improvements in functional or long-term mortality outcomes. From a safety perspective, there were no significant differences in any of their serious adverse events, including venous and arterial occlusive events or seizures. And in fact, when considered overall, the TXA group actually had significantly fewer serious adverse events at 90 days compared to placebo. So the authors concluded that TXA does not significantly affect functional status at 90 days, despite a reduction in early deaths and serious adverse events in patients with ICH. Although this study was quite strong, one big limitation was their choice of inclusion time of up to 8 hours after symptom onset. The reason I say this is because their median time to randomization was around 4 hours, at which point only a small percentage of patients would have still been bleeding. In fact, Dr. Dalit Shahi, a stroke neurologist here at TOH with particular expertise in ICH research, said that while TICH2 was an overall negative trial, he suspects this is because they studied the wrong time window. He states that the rule of thumb is that expansion will occur within the first 6 hours, with only about 10% still expanding at that point, with the sweet spot really being within the first 2 hours. He also gave me the insider scoop that the upcoming 2022 AHA guidelines will state that there's insufficient evidence to recommend the use of TXA in emergency settings for spontaneous ICH, but given its good safety data, it could be considered in exceptional circumstances or as a heroic measure. So your take-home message is that currently we don't have enough evidence to support the use of TXA in spontaneous ICH, even though it has a good safety profile in this population. Our treatment should still be focused on ABCs, ICP, and blood pressure management. Ultimately, we need larger studies before we can really understand its role in this population, or whether there's a subset of patients who may benefit, such as those with lower systolic blood pressures or those treated early. But until then, will I be using TXA for my patients with ICH? Not likely. Unfortunately, though, it doesn't look like we'll be getting many more answers anytime soon. With ongoing recruitment issues and small sample sizes in the recent and upcoming studies, it seems like the results of the TICH2 trial will be our only real guide for the foreseeable future. Next and last on our list for this part of the talk is hemoptysis. I'd like to spend a few minutes discussing the emerging role of TXA for this presentation. Hemoptysis is a frequent symptom of pulmonary disease and refers to bleeding from the major airways or from the lung parenchyma itself. There are multiple causes of hemoptysis, with the most common being lung cancer, bronchiectasis, and pulmonary infection. But regardless of the cause, pulmonary bleeding can be really scary and sometimes requires prompt intervention. Hemoptysis is usually categorized as either non-massive or massive, with a volume of more than 200 mils in 24 hours typically being used to differentiate between the two. Current definitive therapies include bronchoscopy with iced saline or epinephrine, balloon tamponade, electrocautery, arterial embolization, and surgical intervention. And these are most useful when the patient's source of bleeding can be identified. But when the source is unknown, therapies are pretty much limited to airway management and correcting coagulopathy. This is why TXA has been of particular interest, especially in the ED setting, when we often don't know the source of bleeding. Let's start with a case. Mrs. H is a 69-year-old lady with a history of stage 4 lung cancer and a recent PE for which she is on rivaroxaban. She presents to the ED with a one-day history of multiple episodes of hemoptysis after receiving chemotherapy the day before. Upon arrival to the ED, she begins coughing up large amounts of blood. She's tachycardic at 140 and is in respiratory distress. Her code status is DNR with no intubation. Her chest X-ray is consistent with diffuse alveolar hemorrhage. You place her on high-flow nasal cannula, but she's becoming somnolent. What options do we have for her? Should we give her TXA? And if so, how and how much? Let's take a look at some of the evidence and come back to her case in a bit. In a recent Cochrane review, there were only 2 RCTs found that looked at the use of TXA in hemoptysis, one looking at IV and the other at oral administration. Neither study found TXA to lead to remission of bleeding by 7 days, but when pooled together, there was a significant difference in the duration of bleeding, with no adverse events reported. But it's important to note that these studies looked at the use of TXA over many days, which is less relevant to us in the ED. Recently, more focus has been on inhaled TXA, as we'll discuss next. Most of the evidence we have so far on inhaled TXA for hemoptysis is based on case reports. Since 2009, there have been 6 published case reports on 15 adult patients. Most often, the cause of hemoptysis was related to lung cancer, bronchiectasis, or alveolar hemorrhage, but the causes and severity of bleeding varied across studies. Doses ranged from an initial dose of 250 milligrams up to 2 grams, potentially followed by repeat doses of 250 to 500 milligrams every 6 to 8 hours. In almost all cases, bleeding usually stopped within minutes of administration. And overall, nebulized TXA appeared to be very well tolerated, with only one reported adverse event, which was bronchospasm, that resolved easily with bronchodilators. These positive findings were also seen in an observational trial in pediatric patients published last year. Out of the 19 kids in their study, only one didn't stop bleeding, and in that particular case, the child was on anticoagulation with heparin and was on ECMO. In all other cases, the bleeding stopped with inhaled TXA usually within 1 day, and there were no adverse events reported in any case. Since the 2016 Cochrane Review, there was an RCT published that looked at the use of inhaled TXA in hemoptysis. This was a small RCT on 47 patients with non-massive hemoptysis. They were randomized to receive either nebulized TXA at a dose of 500 milligrams TID for up to 5 days versus placebo. One of their primary outcomes was the rate of complete resolution of hemoptysis within 5 days. Secondary outcomes looked at rates of interventional bronchoscopy, IR embolization, or surgery, and the rates of side effects, among others. Complete resolution of hemoptysis within 5 days was noted in 96% of patients, which was significantly different from the 50% noted in the placebo group with an NNT of 2. The percentage of patients requiring procedural intervention was also significantly less, with an NNT of 5, and there were no adverse events in either group. So in conclusion, the author stated that inhaled TXA can be safely and effectively used to control bleeding in patients with non-massive hemoptysis. This study was limited by its small sample size and the fact that they looked at a 5-day treatment course, making it less relevant to ED practice. They also excluded patients with hemodynamic compromise, which is the very group that we'd likely consider giving TXA to. However, it does remain the only RCT that we have to date on inhaled TXA for this indication, so it's definitely worth noting. Now, let's go back to our case on Mrs. H, who presented with hemoptysis and hemodynamic instability. After some thought, you decide to give nebulized TXA a try. You give her 1 gram of TXA via nebulizer, and her hemoptysis resolves completely within 10 minutes, and her vitals normalize. She has an uneventful admission and is safely discharged home 5 days later. So while this sounds almost too good to be true, this is actually a true case published in the Journal of Emergency Medicine in 2018, which I thought was pretty cool. But what do the experts have to say? I had the chance to speak with Dr. Michael Hickey, emergedoc and intensivist, about his opinions on using TXA for hemoptysis. He said that while it's not something he's incorporated into his practice, he feels there's very little downside to its use as long as it doesn't delay other more important interventions such as airway management or bronchoscopy. He also said he does believe its effectiveness will likely depend on the source of bleeding. For example, it probably won't have much effect on a high-pressure bronchial artery bleed, but acknowledges that we probably won't have this information readily available to us in the eMERGE. I also chatted with Dr. Madeline Warwick, a respirology fellow from Queen's, about this, and she felt similarly. She actually said she uses it regularly for her patients with hemoptysis, at least as a bridge to more definitive interventions or imaging. She tends to use 1 gram of TXA given IV for cases of moderate to massive hemoptysis and reserves the inhaled format for patients who are at higher risk of clotting. So now maybe you're wondering how you'd actually go about nebulizing TXA if you were going to use it. Well, it's super easy. Ask for a 1 gram vial of TXA, pour your dose into the nebulizer chamber, and voila, you're good to go. Some sources also recommend adding 5 to 10 cc's of normal saline to the nebulizer as well, but this isn't really necessary, and I would actually advise against it, as nebulized saline itself can induce bronchospasm. If we look at our practice here at TOH, again, we have considerable variability across the board, but it's interesting to see that the majority are considering its use more often than not. So your take-home message for the use of TXA in hemoptysis is that so far, we don't have much evidence to guide us. That being said, the risks appear to be very low, and its use in both IV and inhaled formats is supported by our respirology and ICU colleagues. I would say that it holds value as a temporizing measure, at least until more definitive therapy can be arranged, or could even be considered as a palliative care option. So would I use TXA for my patients with hemoptysis? Totally. Okay, phew, that was a lot of information, but I hope you found it informative and clinically relevant. For the last part of our talk today, I'd like to fire through some commonly asked and debated questions about TXA use in general. We'll address questions regarding optimal TXA dosing, routes of administration, specific clinical considerations, and why we're seeing such differences in the major TXA trials, and finally, the risks associated with use. Let's start with TXA dosing. When going over the literature on TXA use in emergency situations, it quickly became clear to me that we still don't know the best dosing regimens. With IV dosing ranging from a 1 gram bolus up to 10 grams over 7 hours. The CRASH-2 trial dosing of a 1 gram bolus over 10 minutes, followed by another gram over 8 hours in trauma, however, seems to be the leading guide in most studies. In particular, this dose was chosen in trauma cases because it was previously shown to be beneficial in cardiac surgery patients, but it was never actually studied against alternative dosing regimens. That being said, there is significant practice variation across different trauma centers, with several using a 2 gram bolus alone versus the standard 1 gram plus 1 gram infusion. In fact, when looking at our own practices here at TOH, we can see that some variability exists even within our own institution, although the majority of us use a 1 gram bolus and only a small proportion use a 2 gram bolus. So let's see what updates there are to help us guide our practice. Very recently, the TCCC guidelines were updated and have shifted towards giving a 2 gram bolus instead of a 1 gram bolus in military settings, in addition to including TBI as an indication for TXA use. But the question remains, is one way better than the other? Recent pre-hospital research has asked this very question. Both published in the fall of 2020, the ROLL study and the STAMP trial by Guillet and colleagues looked at the effect of a 2 gram bolus with or without subsequent infusion and compared it to the CRASH-2 dosing. Neither trial found a significant difference in functional outcomes or mortality in trauma patients. But on the plus side, there was also no significant differences in adverse events between dosing regimens. So while there's not really enough evidence out there to suggest that we change our practice, the idea of giving TXA as a single bolus does offer other benefits. For one, it frees up an IV line by removing the need to run an infusion for 8 hours. Also, it allows us to mentally offload the need for an infusion, which is an important point since some have actually claimed that one of the biggest harms of TXA is that it can distract us from other more important life-saving interventions. In speaking with Dr. Andrew Petrosoniak, Emerge Doc and TTL at St. Michael's Hospital, he acknowledges that giving the 2 gram bolus up front isn't evidence-based, but from a human factors and logistics perspective, the 2 gram bolus is favored and has been well tolerated in the patients in their center. In fact, this is the practice at both St. Mike's and Sunnybrook. Both trauma sites switched over to giving 2 grams up front after realizing that the infusion dose was often being missed in their trauma patients. And apparently, they aren't the only ones who are seeing this. One of our very own Emerge Docs and TTLs here at TOH, Dr. Michael Wu, was kind enough to share data from a manuscript he co-authored in 2014, which showed that this is also a local problem for us too. In their retrospective study on 87 trauma patients, they found that only about 18% of trauma patients received the recommended second dose of TXA within 3 hours of injury, and actually found that the most frequent deviation from the CRASH-2 protocol was failure to administer the second dose. In speaking with both Dr. Wu and Dr. Glenn, who is also a TTL here at TOH, they both support the use of a 2-gram bolus up front. But as Dr. Wu pointed out, ideally, this would be a change that we need to address with a systematic approach involving all care parties, including trauma, critical care, and nursing staff, so that everyone is aligned with the idea. And so I would say that while there's no concrete evidence for or against the use of a single 2-gram bolus, there are many other benefits to using this regimen without any evidence of harm. I believe we should strongly consider switching to a 2-gram bolus protocol, as has been done at the other 2 largest trauma centers in Ontario, especially given that our local data has also shown that the second dose is often missed. Now moving on to routes of administration. So far, we've talked about the use of intravenous TXA for different indications, touched on its role as a nebulized drug, and know from previous research that it's great when applied topically in epistaxis and when given orally for heavy menstrual bleeding. But what about intramuscular use? Some have questioned whether intramuscular use in states of shock would result in poor systemic absorption due to decreased blood flow to the skin and muscle. Last year, a small prospective study looked at the pharmacokinetics of IM-TXA in trauma patients for the first time. 2 hours after getting an initial IV bolus, they administered 1 gram intramuscularly and measured serum concentrations. They found that therapeutic concentrations were achieved in as little as 15 minutes following IM administration, with no reported serious adverse events. So the authors concluded that IM-TXA is a well-tolerated drug that rapidly reaches therapeutic concentrations, even in patients with signs of shock. And while this paper won't change our practice yet, this certainly may be something that's coming around the corner for us. On to our next section about clinical considerations. When we look at the results of the major TXA trials, it does make you wonder why we're seeing such differences in outcomes for the different types of bleeding. The simple answer is not all bleeding is the same. In speaking with Dr. DeWitt, a specialist in emergency and internal medicine with particular interest in thrombosis, she states she isn't surprised that there are mixed results in trauma and in other forms of bleeding. This is because there are many different things that affect bleeding itself, as well as the effect the bleeding will have on the patient. For example, a small bleed into the spinal canal can have devastating consequences for patients, whereas a similar volume elsewhere may be of little consequence. Also, the dynamics of traumatic bleeding, which is often fast onset and associated with very early healing, are different from the mucosal bleeding seen in gastritis or epistaxis, for example, which is typically slower and more gradual, and this has likely affected the results that we've seen in different trials. Lastly, the side effects of TXA may also play a role in the outcomes that we've seen. For example, the effect of hypotension, which can happen with rapid IV administration, is likely to be much more devastating in patients with traumatic brain injury than it is in other conditions. Taken all together, these factors help us understand the differences that we've seen in the major TXA trials so far, and certainly provide an outlet for future research. Now, we've just spent a long while discussing when and how to use TXA and its possible benefits, but as promised, we'll now take a look at its potential risks. When reviewing the literature, the most commonly studied adverse events are venous and arterial clots and seizures. Looking at our TOH survey results, it seems as though the most common concern with the use of TXA is the risk of VTE, but most people actually consider TXA to be safe. Let's see if we can address some of these concerns today. Generally speaking, if you look at all of the literature, you're going to find a lot of mixed results on rates of adverse events. But this really isn't surprising, given that the studies used a wide range of dosing with different timings and durations of therapy and a wide number of different indications for use. But if we narrow our scope down to studies that are actually relevant to our practice and emerge, we find that most of the trials have failed to show significant differences in rates of VTE, arterial thromboembolism, or in seizures, with the exception of 2 studies as shown here in this table. the MATTERS trial on trauma patients in military settings, which showed a significantly increased risk of VTE, and the HALT-IT trial on GI bleeding, which showed an increased risk of VTE and seizures. If we look at the details of these two trials individually, we can speculate as to why these adverse events were more likely. In the MATTERS trial, the degree of injury severity was significantly higher in their TXA group than in their placebo group. Since we know that injury severity is an independent risk factor for thrombosis, it's really not surprising that a higher rate of VTE was seen in this group of more severely injured patients. In the HALT-IT trial, they used a higher dose of TXA for a longer period of time than was used in other trials. Specifically, they used a total of 4 grams over 24 hours. It's possible that the longer duration of therapy increased the risk of VTE, and the higher dose used increased the risk of seizure. Another really important point to consider in the HALT-IT trial is that almost half of the patients had cirrhosis. These patients are known to be hypercoagulable at baseline, which may have also contributed to the increased rate of VTE in this study. That being said, the rates of adverse events in these trials were pretty low overall, at 5% for VTE in the MATTERS trial and only 0.8% for VTE in the HALT-IT trial, and when reported, this didn't result in any increase in mortality. So after working on this presentation, I'd place myself in the category considering TXA to be generally a safe drug, acknowledging that there are probably certain populations, such as those with higher injury severity scores, who may be more at risk of adverse events. That being said, it's also likely that these patients are the ones who stand to benefit the most from getting TXA in the first place, and the mortality benefit would likely outweigh the risk of adverse events in those cases. So your take-home messages for this section are that a 2-gram bolus appears to be just as effective and safe as a standard 1 gram plus a 1 gram infusion. It may also offer additional benefits, such as freeing up an IV line and allowing for earlier mental offloading in a resuscitation scenario. Intramuscular TXA has shown potential in offering another means of administration, but we need more evidence before using it in practice. With respect to specific clinical circumstances, it's important to remember that not all bleeding is the same, and the effectiveness of TXA will depend on multiple factors, including the timing of administration, the type, size, and location of the bleed, and lastly, and very importantly, overall, TXA appears to be a very safe and well-tolerated drug. In summary of our talk, I created a little table highlighting my recommendations for the use of TXA based on what we've discussed today. Overall, I would recommend its use in TBI, acknowledging a likely larger benefit in those with mild to moderate injury. I also recommend its use in moderate to severe hemoptysis and in early trauma. And generally speaking, I recommend against its use in GI bleeding, as well as in spontaneous ICH. Lastly, I would encourage you all to consider moving towards a 2-gram IV bolus in your trauma patients. This practice comes with numerous benefits and is supported by other major trauma centers in Ontario. This brings us to the end of our talk today. As I'm sure some of you may be feeling, much as I felt when doing my research for this presentation, that despite being an old drug, we still have much to learn on TXA, and we need to be careful in avoiding a uniform approach to the treatment of our bleeding patients. That being said, I hope I've shed some light on the available evidence out there for you today in this crash course on TXA, pun intended. Now it's up to you to decide if and how it'll change your practice. Before we wrap up, I'd like to take a moment to sincerely thank my amazing supervisors, Dr. Miguel Cortel-LeBlanc and Dr. Mike Ho, for their invaluable guidance, support, and mentorship, both in the making of this talk, but also in residency as well. I'd like to thank the following physicians for their amazing insights and expertise: Drs. Deleuze, McCurdy, Dalit-Shahi, Stotts, Hickey, Warwick, Seeley, Petrosoniak, Wu, Glenn, and DeWitt. I'd also like to thank Dr. Tiffany Lamb for hooking me up with some local TOH data. And lastly, but not least, I'd like to thank Drs. Tran, Wong, and Nandalal for supporting me through everything, including this grand rounds. Thank you all so much for listening. I'd be happy to take any questions.